Hello and welcome to the Point of Care podcast. Today's Quick Admit episode will focus on admitting and managing patients with AFib with RVR. To follow along with our online template and see a sample EHR dot phrase, check out the link in the show notes. Note that this episode assumes you already have a baseline understanding of atrial fibrillation. For more on that, check out our AFib clinical review episode and article. Let's dive in. First, assess the ABCs and triage. Is the patient unstable? Look for hypotension, altered mental status, ischemic chest pain, acute heart failure, pulmonary edema, respiratory distress, or signs of shock. If unstable, use synchronized cardioversion, starting with 100 to 200 joules biphasic. If that persists, increase to 200 to 360 joules with repeated attempts. If time permits, consider sedation with 2 to 5 milligrams of IV midazolam. Make sure the patient is on continuous telemetry and pulse oximetry. Use the CHADS VASC score to assess stroke risk. This will help guide your anticoagulation decisions. Next, let's review the information you should look for in the patient's chart. Check for prior EKGs. You want to establish a baseline rhythm. Review echo results for structural abnormalities or valvular disease. Note any prior cardioversion attempts or ablations. Check the patient's anticoagulation history, including fills and most recent coags. Determine what rate or rhythm medications they're prescribed. Finally, note any past medical history of reversible etiologies for atrial fibrillation, such as thyroid dysfunction, infections, or alcohol use. There are some can't-miss diagnoses that can be associated with AFib with RVR. Be sure to rule out acute coronary syndrome, pulmonary embolism, thyrotoxicosis, sepsis, and pericardial tamponade. Make sure you know if a patient has Wolff-Parkinson-White syndrome, as it has implications for management. Moving on to admission orders. For labs, order a complete blood count, basic metabolic panel, magnesium and phosphorus, TSH, liver function tests, coags, troponin, and NT-proBNP. Consider a urine drug screen too in appropriate situations. For imaging, get an EKG and chest X-ray. Consider a transthoracic echo or TTE if the AFib is new onset or if there's concern for structural heart disease or worsening heart failure. Now let's discuss initial treatment to consider. First, address the underlying etiology. Give fluids if you're concerned about hypovolemia or sepsis. Consider anticoagulation, lytics, or revascularization if it's PE or ACS. Use diuretics and afterload reduction for heart failure. Give beta blockers among other treatments for thyrotoxicosis. For rate control, consider intravenous metoprolol, 5 milligrams every 15 minutes, up to 3 doses, or diltiazem, 0.25 milligrams per kilogram bolus, followed by an infusion at 5 to 15 milligrams per hour. If rate control fails and blood pressure allows, consider an amiodarone loading dose for rhythm control. If needed, generally start with phenylephrine for pressure support. Electrical cardioversion is an option if the patient is unstable or if the AFib onset was less than 48 hours and there's no thromboembolic risk. Start anticoagulation with a DOAC unless contraindicated. Use warfarin for valvular AFib. And finally, maintain electrolytes. Keep potassium greater than 4 and magnesium greater than 2 to limit ectopic beats, which can promote flipping into AFib. Next, let's talk about the HPI. Key questions to ask include: what symptoms are they experiencing? Palpitations, chest pain, dyspnea, fatigue, or dizziness? When did those symptoms start? Was it sudden or gradual? How long have they persisted? And have they had any previous episodes? What are the precipitating factors, such as recent illness, stress, or alcohol intake? And do they have any other associated symptoms like syncope, presyncope, or weakness? Inquire about cardiovascular history, including hypertension, CAD, valvular disease, or heart failure. What meds are they on? Have they had any recent changes? Are they using anticoagulation, and are they adherent? And finally, what other risk factors do they have? This includes age, diabetes, hypertension, and vascular disease. Here are some things to note on the physical exam. Note the patient's general appearance. What is their distress level? And what is their mental status? Listen to the heart, noting any irregular rhythms, the rate, murmurs, or an S3 gallop. Auscultate the lungs. Are there crackles, wheezes, or increased work of breathing? Examine the extremities for edema, pulses, and signs of arterial insufficiency. Inspect the skin for pallor, diaphoresis, or cyanosis. This brings us to the etiology. what are the potential causes? Consider causes like hypertension, CAD, valvular disease, or cardiomyopathy. Think about pulmonary causes including COPD, pulmonary embolism, or pneumonia. Endocrine causes can include hyperthyroidism and rarely pheochromocytoma. Metabolic causes include electrolyte imbalances, especially potassium and magnesium. Toxic causes can include alcohol use and use of sympathomimetics. And finally, other causes like sepsis, a postoperative state, or obstructive sleep apnea. If you remember nothing else, in general, it's okay for patients to be in AFib in the hospital unless it leads to rapid ventricular response and/or instability. AFib management in the inpatient setting focuses on 3 key aspects: rate control, rhythm control, and stroke prevention. AFib with RVR is unlikely to be the sole source of hypotension unless the heart rate is greater than 150. Keep in mind other etiologies that can precipitate AFib and RVR, including MI, heart failure, hypovolemia, PE, sepsis, and treat the underlying disease. Start with IV fluids and beta blocker or calcium channel blocker pushes. Then trial amiodarone to cardiovert and prevent flipping back into AFib. Add pressors with phenylephrine as the first line. Then electrically cardiovert if the patient remains unstable. Avoid rhythm control unless emergent if the AFib has been present for greater than 48 hours or the patient has not been on anticoagulation for at least 3 to 4 weeks. This is due to the risk of throwing a clot from the left atrial appendage. Historically, rate control is preferred to rhythm control. However, with the wider availability of ablation, early rhythm control may be the ideal standard in many patients. Lastly, ensure appropriate follow-up with cardiology for long-term management and consideration of ablation or other advanced therapies if indicated. That's all for this episode. Check out pointofcaremedicine.com for more content like this.